Society. To begin with our session, I would like to invite Dr. Samar Kumar Basak to initiate the session. Over to you, Doctor.
Thank you. And I will invite Professor Elmer too for his keynote address in this conference, and he will be speaking of post-keratoplasty infection. Over to you, Professor Elmer too.
To thank the organizers of the All India Ophthalmology Congress 2021 for inviting me to speak on post-keratoplasty infections, concepts, and controversies. My name is Elmer Tu. I'm professor of clinical ophthalmology at the University of Illinois Eye and Ear Infirmary, Chicago, Illinois, USA. Listed on the slide are my disclosures, which have no bearing on today's talk. Corneal transplant-related infections are not a new problem. In the early days of corneal transplantation, bacterial endophthalmitis was a major problem, although they did find that cultures were not concordant with the isolated organism for bacteria, they were for fungal elements. Because of this, a move was made to add antibacterial supplementation in the form of gentamicin and streptomycin, which was successful in reducing the relative proportion of infections from bacterial endophthalmitis and keratitis. You can see here the curve inverted in the late 1990s to the point where bacterial infections were less common than fungal infections. Fungal infections were largely ignored until the advent of endothelial keratoplasty, and here is the first report of an endothelial keratoplasty-related interface infection published out of Iowa in 2009. Increasing anecdotal reports resulted in a study done by the EBA retrospectively from 2007 to 2010, which did identify a slightly elevated incidence of fungal infections in EK versus PK, but was not statistically significant. Because of limitations of that study, a snapshot of 2013 was performed, and in this particular case, there was an increase in the incidence of fungal infections, about a tenfold increase in endothelial keratoplasty versus penetrating keratoplasty. Further, a higher rate was found in eye bank prepared tissue versus surgeon prepared tissue, and it confirmed that the large proportion of these are yeast or candida infections. The early assumption was that the unique intralamellar structure of endothelial keratoplasty transplants contributed to the increased rate of infection. I, however, had the opportunity to look at the 2013 Eversight data and was surprised to find that, in fact, the donor rims that were prepared for EK had a significantly higher rate of contamination than those that were not processed and destined for PKP. In looking at possible factors, I concluded that the increased temperature exposure that was required for EK processing in the eye bank would potentially increase growth of pathogens. We took this hypothesis to the laboratory and was able to confirm that room temperature exposure would result in exponential increases in the number of pathogens, especially Candida. The concepts behind contamination and subsequent prevention of infection are common to both resistant bacteria as well as fungi. There are a number of issues regarding prevention which are controversial. We know that all transplant tissue is contaminated at its source at some level. We try to avoid many of these by donor screening for sepsis and other possible infections. During the recovery, there's an extensive site and donor eye preparation time to sterilize the surface where most of the organisms reside. And during tissue storage and transportation, ensuring refrigeration, antimicrobial supplementation, and aseptic technique when processing occurs. It is important to note that infection risk increases with pathogenicity, but also with the number of organisms, that growth is exponential, meaning that earlier interventions are the most effective at reducing contamination. A major step towards sterilization of the surface was published in 2019, where instead of one, there were 2 betadine soaks of the whole globe, which resulted in a significant decrease in the number of positive fungal rims, as well as a number of clinical transplant-related infections. Antifungal supplementation is more controversial. There were 2 articles last year which suggested that of all the antifungals, that amphotericin B had the best chance of being cost-effective. This did assume a rather high level of effectiveness in preventing infection, as well as a high incidence of fungal infection. Unfortunately, the dose of 0.255 micrograms was found to be ineffective at reducing fungal contamination with warming cycles included in the study. And further, concentration of the most antifungal drugs are tightly limited by toxicity to human cells more than they are for antibacterial drugs, as they usually attack structures in the fungus that are similar to human tissue. This failure should not have been a surprise. Looking at European data where it's commonly used at that dosing, it was found to be ineffective at sterilizing, and even concentrations of 2.5 and 5 micrograms per milliliter still allowed contaminated tissue to proliferate in organ culture. Dr. Shields and Farid presented a paper just a couple of weeks ago looking at their data, and it was found that Optazol with amphotericin B 2.5 micrograms did not result in a statistically significant reduction in positive donor rim cultures or post-transplant fungal infections, and was certainly non-sterilizing. It appears that the most beneficial strategies for reducing contamination include minimizing warming, reducing source contamination, and antibacterial supplementation. But given the lower incidence, as you see in the lower right, of keratoplasty-related infections, as well as the substantially lower efficacy rate, there are no antifungals that likely meet the standard of cost efficacy for antifungal supplementation. Donor rim cultures are also controversial. We know that from previous studies that fungal rim cultures are predictive and concordant with subsequent endophthalmitis and endothelial keratoplasty-related infections. However, the primary utility would be whether you could institute either antimicrobial prophylaxis or facilitate treatment should an infection arise. Antibiotic prophylaxis, however, is controversial. In surgical site infections, it's known that antimicrobial prophylaxis is beneficial. However, studies are very firm in that they must be given prior to the surgical incision. Efficacy drops by 50% if it's given after the surgical incision up to 60 minutes, and the rate of infection is 5 times greater if given greater than 120 minutes after incision. This is far different than what is proposed for corneal donor rim cultures, where the cultures may come back anywhere between 1 to 30 days later, and giving prophylaxis at that point is likely to be less useful. There's also scant evidence that antifungal prophylaxis works in this fashion. An article published in 2017 purported to show a decreased rate of interface infections in those that were prophylaxed, but these were not statistically significant, and one of the donors in the non-prophylactic group caused 2 infections, which would skew the results statistically if properly handled. Further, there are a significant number of patients who develop infections who have either a negative culture or have not had a culture performed at all, meaning that antifungal prophylaxis would likely need to be applied universally in order to achieve the numbers that would make it cost-effective. In summary, antimicrobial prophylaxis has significant challenges, including which antifungal to choose, likely an azole, whether it's topical, oral, or intrastromal, or intracameral. They would likely have to be done earlier on in the process than when fungal cultures return from a donor rim, and would need to be instituted even before surgery occurs. And finally, treatment. A common option is Aushad penetrating keratoplasty muscimolbucin, published early on, the very successful results in doing full thickness corneal transplants to encompass the interface infection with good general success. We were the first, however, to describe the successful management of interface keratitis with intrastromal injections, both in Dissection you see on the right and in Dmacc on the left. A presentation by Tony Aldave at the Cornea and Eye Banking Forum in the fall of 2020 looked at the past Dmacc infections reported to ORs. And interestingly, of those patients who received intrastromal injections, 86% had a resultant vision of greater than 20/50, while those who did not were only able to achieve 20/50 or greater in 35% of cases, suggesting that intrastromal therapy should be part of the armamentarium in the treatment of late onset interface infections. In summary, there are a number of strategies for preventing post-keratoplasty infection, which are applicable whether your problem is fungal infections or resistant bacterial infections, depending on where you are. Prevention should concentrate on early elimination of contaminants, especially with broad-spectrum antiseptics. Antibacterial prophylaxis may be effective, but antifungal prophylaxis is limited by toxicity to mammalian cells or insufficient cost efficacy. Maximizing refrigeration time to reduce growth is also important. Donor rim cultures can be helpful primarily to aid in early treatment when an infection is realized. Its use in prophylaxis, however, is controversial and likely requires universal application earlier on in the process in a way that's different than we currently employ it once donor rim cultures are positive. And finally, treatment should include the consideration of intrastromal injections, which appear to give the best results. Thank you again for the invitation, and I in turn would like to invite you to the World Cornea Congress in my hometown of Chicago, immediately preceding the American Academy meeting, September 28th and 29th, 2022. Best of health to all.
Thank you, Elmar, for lovely summary of this post-infection keratitis. Now, if you have any question, any of the panelists, Rajesh, do you have any question to Elmar? Dr. Rebati, do you have anything to say about?
No, sir, not to Dr. Elmer, but to you. In our scenario, we don't see that many increased number of infections in after we start the lamellar surgeries.
That's right, absolutely.
Probably because I mean, here usually the surgeons prepare the tissue. That could be one reason. I'm not very sure. Right?
No, I'm absolutely positive. I mean, this is more of an eye bank prepared tissue issue, and statistically that's true from our studies. So, but it's because of the time between the introduction of the pathogen to the lamella and how it's able to proliferate before the surgery, which is often 24 hours or more. So, in your case, the surgeon prepared tissue, the chances of proliferation or the time is quite short. So I think that is absolutely true. But I think many of the concepts do apply also to some of your resistant bacterial infections that may occur and that are not covered by the normal gentamicin and streptomycin that are in the storage media. But as far as aseptic technique and recoveries and the different prophylaxes and even the value of donor rims are more for bacterial in your case, most likely.
Thank you, Elmar. So we'll start our course. So can you see my slides?
Yeah, we can see.
Yeah. It is the same course like last year. Dmacc made simple for the beginners.
Sir, please put on slideshow, sir.
Yes, full screen. Now it is fine?
Yes, sir.
So we do not have any financial interest, but you know the difference between the Dissection and Dmacc, the same patient, the patient always says, and also surgeon feels that this eye, left eye is always better. And Dissection is always about 80 to 150 micron more. It is not anatomically perfect, also visually. Whereas in Dmacc, we know that from the very first day, we get a surprisingly very good result, and this perfectly anatomical and higher chances of gaining 20/20 vision. So this is all we know that started long time back, but initial slow adaptation all over the world because of steeper learning curve and initial understanding problem, how the scroll behaves. And every dissection started initially then with higher rate of unsuccessful attempts and primary donor failure, they again back to dissect, and they again after learning little more, and they started doing Dmacc. So if you see the US data, even the last year data, I do not have, probably little down, but if you see that gradually 2011 to 2019 data, and now 43% of all EKs are actually Dmacc in Western world. I know that we in India, we are doing about 5,000 to 6,000, what I am talking about pre-pandemic figure, and more than 100 surgeons have started actually doing Dissect, and at least 25% of them are doing Dmacc regularly. So we have a course outlined like introduction and case selection. Then I'll be talking on donor roll preparation and basic steps in Dmacc. Then Dr. Rajesh will be talking about different insertion techniques on Dmacc and unfolding. Then Amrita will be joining with IOCD guided Dmacc. And lastly, Dr. Ravati will be talking about complication and management. So I call upon Dr. Shoham to start his talk.
Thank you very much, sir, for including me in the session. I'll quickly get my slides going. So I'll be talking about the indications and case selection for Dmacc, mostly from a beginner's perspective. I have no financial interest in this talk. So to keep it simple, same as Dissect, the indications for Dmacc is endothelial dysfunctions. The most common indication that we come across in our country is post-cataract surgery, corneal edema. A good pseudophakia is what you should begin with normal anterior chamber anatomy and IOL in the bag, which behaves, and a round central pupil. Such cases of advanced long-standing PBK Dmacc is possible, but it might be better to get it staged, do an epithelial debridement first, improve the visibility, and then as a stage 2 procedure, do the transplant itself. Following tasks, that is a little bit challenging because there is a chance of more increased bleeding, and also the fibrin thread formation might interfere with the graft unfolding. In case of PBK in presence of an ACIOL, Dmacc is possible, might be a little daunting for the beginner. However, if you want to do the Dmacc in presence of an ACIOL, ensure that the chamber is good, has good depth, there is a stable IOL position, and that the patient had enjoyed a good vision with that ACIOL for a long duration. But if these factors are not present, then better to go for an IOL exchange, maybe a scleral fixated or an iris fixated, retro-iris fixated IOL, maybe with the help of your VR colleague. FECT in eastern part of our country, we see a lot of this, quite similar to that of the Western world. These are again very ideal cases for the beginner. And if you are the primary surgeon, nothing like doing a Dmacc triple for these case situations. And in case of failed grafts, so if it's a failed Dissect, then doing a Dmacc is quite simple. But in cases of failed PK, the initial graft size has to be considered, and also the anatomy of the posterior step, where if there is a lot of steps in the posterior graft host junction, then your Dmacc graft might not stick properly. So a Dissection will be better in these situations. In case of previous glaucoma surgery, again, due to the presence of a trabeculectomy or a tube shunt, the air tamponade maintenance is difficult, and the tube itself can cause difficulty in unfolding, and there will be increased endothelial cell loss. Other indications that we encounter are the posterior polymorphous dystrophies, CHED, eye syndromes, and post-viral endothelial decompensations. These again would be moderate to difficult due to the challenging AC anatomy. Contraindicated for beginners would be cases like this, where there is a large vitreous blob in the anterior chamber, extreme levels of scarring, or maybe a very large iridectomy presence where the graft might dislocate posteriorly. So if the visibility is poor, even though the indication is endothelial dysfunction, it's better to go for a full thickness or Dissection in these cases. So if we look at our data and in Disha Eye hospitals, so most common indication is PBK followed by FECD, this is slightly more than the rest of the country. Then we also do Dmacc in a significant number of failed grafts and eye syndrome and post-viral endothelitis. So coming to the workup, so as a beginner, it's always better to maintain your own Excel sheet and a tabulated form of the patients. So it will be better so that you can take a look back at your data once you're doing. So include the diagnosis, record the visual acuity preoperatively, and also the diagnosis in the other eye. So many times in a PBK, endothelial dystrophy in the other eye is often missed. Look at the lens status, because that would determine whether you are going for a triple procedure or only Dmacc alone. Look at prior glaucoma surgery and adjust medications accordingly. Any IOP rise that is there has to be considered and started treatment preoperatively. And in case of pseudophakic eyes, look at how the IOL stability is and where the IOL has been implanted. And the other important things in AC anatomy to consider is the pupil. In case of a very large iridectomy scar, might be prudent to do a pupilloplasty. And in case there is a vitreous in AC or you're suspecting vitreous in AC, better to have the vitrectomy cutters ready. Pre-op workup includes ultrasound B scan, which includes the retina as well as the optic nerve health status, axial length for biometry, and biometry also from the other eye, anterior segment photography and OCT more for documentation purposes, and then macular OCT if the visibility allows, because in some of these PBK cases, there is always almost a CME present, so you can address it at the time of surgery by giving a subtenon Kenacort injection. So whether to go for a triple or a Dmacc alone in case of phakic patients, above 40, it's better to go for a triple procedure, then which avoids the damage to the graft for doing a subsequent phaco. In younger patients, of course, single phakic Dmacc is possible, but they should be informed that the cataract formation is usually early due to the surgical manipulation and the postoperative medication itself. In eye syndrome and certain cases of complex AC anatomy, even with younger patients, it is better to do the cataract in the first sitting itself. And the choice of IOL is very important. Always go for hydrophobic with myopia target is there, but not as much as in Dissection. Toric IOLs may be considered in very clean cases of Fuchs, but better to avoid multifocal IOLs. Specular microscopy of the other eye is important in case you want to know if the other eye has any subtle corneal pathology going on there. And also it is sometimes important to give to guard the cataract colleague who has done the primary surgery sort of a medico-legal implications there. So definitely in our country with such high cataract surgical rates, we have to automatically the byproduct is that we are producing a lot of pseudophakic bullous keratopathies every year. So definitely EK is the way to go about it. And as a natural progression for an EK surgeon, Dmacc becomes the next step after doing a Dissect. So the ideal cases for the beginner would be sort of a good pseudophakic bullous keratopathy where the IOL is in place with good anterior chamber anatomy, Fuchs dystrophy, and definitely we should ensure that there is no vitreous in AC and that there are no synechia present. Thank you very much.
Thank you, Shom, for wide area of coverage. Anything to add to other panelists? Dr. Rajesh, Dr. Namrata, Dr. Revati?
Sir, if a patient already had multifocal IOL and if they come with pseudophakic bullous keratopathy, if we plan for a Dmacc or something, should we have to leave the IOL in place or?
We can keep the IOL. I have 3 occasions I did this. One eye multifocal, that one in Dissect time. Now in Dmacc time, I had to do, in other eye, I had to do multifocal. The same multifocal, but in the Dmacc, probably no, but primarily, I don't think Dmacc, Rajesh can answer, but even the Elmar can highlight if multifocal as a primary surgery. Dmacc triple with multifocal IOL.
Oh, so Samar, I think we're much more comfortable with multifocals in Dmacc than Dissection for sure. I don't know that we universally do it. We obviously talk to the patients about it, but I think with Dmacc, especially early, if there's no corneal scarring or structural changes, I think that it's reasonable to consider a multifocal in those patients.
Okay. So next, I'll be covering the donor preparation and basic steps. So is it visible now?
Yeah.
Yeah. So donor preparation, I'll be showing my way of doing donor preparation. Normally, as Elmar was telling that in US, 80% of US surgeons use iBank prepared tissue. They always, Tony used to say that they are spoiled. And in fact, there is a good lecture I have heard that EK surgery in US starts in the iBank only. But nowadays they have luxury to have pre-strip, pre-stamp, pre-stent, preloaded, everything ready-made coming in this kind of pack. And they just take the thing and do the recipient preparation and transplant the graft. But India, all surgeons actually prepare their Dmacc roll, and probably the damage during donor preparation is between 1 to 4 to 5%. So there are many techniques of doing donor preparation, like classical manual peeling technique, starting from trabecular meshwork or a prefixed refined cut, then scuba technique, the pneumatic dissection, reverse big bubble, like people are using for PDEC surgery, then hydrodissection and lamellar dissection. Last year, this was published by Tan et al. I prefer classical manual peeling with ripen blue assisted. It gives me better visibility. I need this kind of instrument. And stamping I used to this. And this regular tape lumbar, the hole is sealed actually. So it retains, it doesn't leak the trypan blue into the field, it keeps. So I prepare the tissue just before donor insertion after doing PI of the recipient. And that time I give air tamponade, which is there for 5 to 7 minutes. This tamponade actually basically helps in two ways. One is it stops bleeding for PI and it clears the edematous cornea to some extent. This is my experience, and it also saves time. And this is the air fill 5 to I prepared this graft. My technique is like you have seen. So it is just like a 9.5 or 10 millimeter. Our corneal diameter is little lower. So I use 9.5 diameter. Then I remove the peripheral DM. Then with the help of McPherson, I just leave the edges of DM. Then with single hand, I just peel the tissue towards like 6 o'clock to 12 o'clock position. And then put a stromal punch of 3 millimeter. Sometimes it hinge. So that hinge actually gives a good look, but it is more stromal tissue, then you have to cut it. Otherwise, it sometimes gives mess. Then S mark, flipping the block. Then 8 millimeters is standard diameter. I remove the peripheral DM. And this is the donor graft preparation, trypan blue staining, and then shifted to the petri dish and now ready to put it in injected system. So with this technique, I have published my result. The average mean time is around 7 millimeter. So I have used both MK medium and cornisol preserved media. So 7.5 millimeter, though maximum may be up to 17 minutes. And my maximum graft size is like 8 millimeter. And so my data till yesterday, I was checking my data. So the donor tissue loss is only 0.6%. And this is the different kind of, I tried to say that because the peripheral endothelial cell count are more, this is now established. And you see the corneal endothelium is like that, more cells in the periphery. So during in situ collection, our technician actually gives 2 scratch marks at 12 o'clock position so that we could identify the superior cornea. So nowadays we are trying to do this, which is Dmacc PD, like 2 superior mark. Then this is the graft. After the graft preparation, you see that it is much more eccentric, like this side, superior side is 1 millimeter, and from the inferior side, it is right 3.5 to 4 millimeter. So it is peripheral refined gut. If you compare with the central refination, and it is perfectly centered, but here it is eccentric. So my intention is trying to give more. So you see that same technique, only thing I am going in the periphery. So with this, you see that after mark, so when I peel the tissue, you see that from one side to other side, there is a lot of, so I am trying to go as eccentric as possible. So this is after graft, and you see the measurement when I take, it is 1 millimeter and 3.5 millimeter. And we have published our data. So this is the one same patient. I did one in 2016. That time actually it was accidental. I go back to the video and I saw that it is peripheral. And this was in the 17. And you see the difference in the cell count after 3 years, and the 2 eyes are different. Then during the COVID time, so we have acute shortage of tissue. Now I have changed a little bit of the graft preparation, so that my intention is use the anterior lamella because we are giving anterior stromal punch. So we cannot use that for whole anterior lamella for other purpose like DAL, therapeutic or tectonic large or as a K-prokaryote. So this is the recently, not
is then stripped off.
not every day I am doing this. Not every day I am this. Only difference is that I have to lift the edge all 360 degree. So this is the new difference. This is a delicate instrument only to lift the DM endothelial complex, and the peeling technique is remaining same. No other instrument is required except you required a one regular bandage contact lens, and it has to be resized because when I take the whole bandage length, the air trapping was difficult. So I made it 12 millimeter size, then make it a central hole. My intention is without changing my surgical technique of putting S mark. Many people are doing without mark. I am not that confident of doing, and mostly many people are advanced cases. So I put this BCL in the interface, then the rest of the procedure is almost similar. So they floated the endothelium complex, then peel that hinge part. That is important in this. And then after that, you just change it. Then you flip the BCL only, then put S mark. And the second, you have to punch in the second Teflon block, not in the same, you just transfer the donor in the anterior lamellar cup and then stain it, and it is now ready for. With this technique, we could save at least 10% of our tissue, and now last year our utilization rate is 103%. So we use almost 47 eyes, and half of them are tectonic and therapeutic, and also for DALC. So take home message that Dmacc preparation, it is not, now we feel that it is not so difficult. Sorry, for initial cases, you need some backup tissue and use any type of media, MK medium, cornisol and optisol GS, and try to take help from the master, watch some YouTube video. And it is always thrilling and with some adrenaline rush during this donor preparation. Thank you. So do you have any question at this point of time regarding donor preparation?
I think, sir, that was a brilliant way of, sparing the tissue and putting it on the contact lens and doing it. And especially in the COVID times, I think that was a very nice way of doing it. That was a great idea.
Thank you. So any other question? So I am going to my next part of the talk, that is the basic steps. And you know that pre-op preparation are all same, both Dissection and Dmacc, nothing different, both same. But surgically, there are some important difference, like case selection, as Sean pointed out. Dissection.
Sorry, sir, I interrupt you, sir. Please share your screen, sir.
I have not shared.
Yes, sir.
Okay, okay. Sorry. Oh, you have stopped. Sorry, sorry. Is it all right now?
Yes, sir. Please go ahead, sir.
Yeah. So pre-op preparation is same, but when I compare some Dissection and Dmacc basic differences, case selection little crucial for Dmacc, but when you are experienced, then you can take bad cases to do successfully Dmacc. Then donor preparation here is only manual. Incision size is between 2.8 to 3.2. One important difference is the DM scoring, which should be larger, 0.5 to 0.75 or 1 millimeter larger. Inferior peripheral irectomy is a mandatory, but many papers are coming, they are not doing inferior PI, but inferior you feel good. Anterior chamber to remain shallower during insertion of the graft. Then graft transfer is like, there are many techniques of graft transfer, but in Dmacc, only by injector technique, and there are different types of injector. And Dr. Rajesh will be talking all these different techniques. And then you have donor unfolding is with BSS and AR, you have to play with. Here it is difficult, that is the most part. And everybody follows no touch technique. And if you have mark on DM side, then you will be doing fine at the end of the surgery. You will feel good that your orientation is right. Donor centration is easy for Dissect, but Dmacc sometimes it is so difficult. Sometimes we always tell that don't try to center it. If it is little off center, and if you try to center, you may spoil the graft. It has happened to me also. So air injection easy for Dissect because just at the edge you just put air, but in Dmacc again the graft may shift towards side, so you have to be at the right at the center or just little paracenter to give air. Full air tamponade, air 10 to 15 minutes, but air tamponade you don't have to keep the patient lying on or table, so you just air fill it and you send the patient in the recovery room for 45 to 60 minutes. So supine position are important for both. So these are the thing. So here the main thing, you have to clear the epithelium, and there are marking. If you give template mark, it helps in your scoring. 8.5 millimeter normally I used to give because the normal graft size is 8 millimeter. Then you have to give side port, and you need to see the internal incision of the side port. It should not be too lengthy, otherwise during air injection it will be having difficult. Then you have clear corneal incision. So this is 2.8, I little enlarged it. Nowadays I do 100% of the cases little posterior limbal, and it gives me, normally I do not put any suture most of the cases. So that is one thing. Damask scoring, same system, so you could use under OVD with trypan blue stain, even under AR. Some of the cases under AR is important, like ACIOL, like SFIOL, like aphakia, where you have difficulty in removing the OVDs. In those cases, you have to do it under AR. Then inferior PR, it may be from external. So external, you have to do it, but it is difficult to go right at the periphery with external. Sometimes you need a different kind of instrument, but in vitrector, it is easier. And there is oozing, not in all cases, but at least 40–50% cases, you need to air tamponade. This air tamponade is important to keep for normal bleeding time, like 3 to 5 minutes. So I keep the air for 3 to 5 minutes, even more, because this time I prepare graft. So donor transfer and insertion technique, I know that Rajesh will be talking of this, and there are many types of injector systems, so plastic cartridge, glasses. There are concept of endo in, endo out, pull through technique, hybrid technique, endoglide, lot of things are there. I am not talking about this. My views on insertion technique, that some techniques are easy, some are difficult. Some techniques may have a better in terms of endothelial cell loss. Glass cannula may be slightly better than plastic, but probably the principle remains same in most of the cases. Consider the cost and time factor. Choose a technique which is consistent outcome in your hand, then master it. I mean, Dmacc is not a huge number of surgery. So if you stick to a particular technique, so it may give you better results with time. Ultimate goal is ease of unfolding and less cell loss. So if you spend less time inside the anterior chamber, your unscrolling or unfolding time, if it is less, so your cell loss. This is the simple injector I am using last 4 years, and it is made of AR140, that cannula, the cartridge from Johnson & Johnson. And every day I used to make one. Whenever I have a Dmacc, I used a new. So every day you have a new one. Just break it and fit it that rubber tube, which is there in your saline tube, and then fit it with 2 cc syringe. That is all. Now it is ready for your injector system, and I am not changed it, though I have goiter, I tried, and I was taking more time. So this is my system. Then the unfolding, I am showing the same. This is the only one technique I am showing. Rajesh will be discussing more. So I don't put any suture. I tap with that needle, and as soon as I realize that I am on a right orientation, immediately I change the cannula. Even I tap the main port also, but it is dangerous. Sometimes it may come out. So go right at the center and put an injection. So this is real time, no fast. So it is real time. It hardly takes 2 minutes time for me, most of the cases. So you see a stamp at the end, and you feel good that your surgery is okay. So immediate post-op is very crucial. As said, that I keep the patient in the recovery room. So maintain that supine position for 1 hour. Then I have a slit lamp there. So I check the patient under slit lamp. The sitting position, if the PI is, air bubble is above the PI, attachment actually happened maybe 6%, maybe 6%. So take home message is, we need to do a lot. Thank you very much. Our next speaker will be Rajesh. Any question? Any addition, comments?
I would make a comment. I know someone was talking about this earlier, but I also fill the eye with air while I'm preparing the graft. And I think it's very beneficial for some of the reasons you talked about, but I also have a very low incidence of having fibrin in the anterior chamber. I think because of that, because it makes it more difficult to form under air. So I think that there may be some advantage in using the air for a period of time between the time you prepare the cornea to receive the new transplant, and to give it a few minutes, it'll reduce the fibrin formation in the AC.
Absolutely, Elmer, agree with you. And I think that makes a difference, preventing the fibrin and thereby having difficulties later on.
So Rajesh.
Yeah, thank you, Dr. Basak, for making me part of your course. And I think the initial presentations by Soham and yourself, you have laid a wonderful foundation on the understanding of Dmacc. And a lot of the points that I wanted to convey have already been covered beautifully. One of the points in donor preparation, I just wanted to make a mention of this illuminated endothelial punch device. Here, because of the retroillumination, you're able to visualize the Desimus membrane quite well. So for people starting out with preparing their own donor tissue, I think this improved visibility of the decimals during the peeling may help reduce tissue loss and may improve their confidence in donor tissue preparation. DM stripping, you already mentioned that it has to be larger than the size of the donor. Commonly, I prefer to do it under viscoelastic, and in certain situations, doing it under air gives you a better contrast, just that retaining the air can be a little bit challenging. So you may need to refill the anterior chamber several times during this process, but it can help identify any residual tags and any retained Desimex membrane. So even if you have used a viscoelastic to remove the Desimex membrane, wash out the viscoelastic, put an air bubble, and see and look for any retained Desimex membrane or irregular tags. PI you already highlighted, using a vitrector and or doing a surgical PI. The only thing about using a vitrector is don't overdo it. Sometimes you can not only create an inferior PI, but you can go through the zonules and eat the vitreous as well. And that can sometimes lead to aqueous misdirection, your fluid going into the vitreous cavity, and you can have a shallow anterior chamber and a raised intraocular pressure. Various injectors are either made of glass or plastic. Some of them have a narrow tip, some have a slightly wider tip, going through either 2.2 millimeter incision or requiring 3.2 or 4 millimeter. Now, when you're inserting the donor, as you inject, because these are all fluid-based injector, as you inject, you first get the fluid going into the AC, so that results in an increase in the anterior chamber depth. And depending on the volume of the anterior chamber, you can have a rise in the intraocular pressure, which is the back pressure. And also with the deep anterior chamber, your donor scroll has a greater space to move. And if you have not yet got your tissue into the eye and you continue injecting fluid, you can have the leakage of fluid either from the edges of your main incision or through the side port, and which can sometimes increase the risk of partial or total donor expulsion. And when you, depending on how you have inserted your donor, the donor can go into one of these many configurations, as very nicely described by Peter Wellman. So you can have a single scroll, simple fold. It can be upside down, or a taco, or a complex origami fold, or the preferred scroll orientation, which is the double scroll. Now, when you get the scroll into your injector, when you load it, you need to have the open end of the scroll facing towards the surgeon before you insert the donor into the eye. So the open end of the scroll facing towards you indicates that it's the correct orientation. So we looked at this small technique that we performed, whereby you can try and achieve a double scroll configuration. So you basically, on the wider aspect of the glass injector, you try to agitate the fluid by doing a back and forth motion. So as you push the fluid out, you find that it opens up the scroll. And then when the tissue goes back into a scroll configuration, it can achieve the double scroll. So on an average, if you do this exercise about 5 to 6 times, in almost 80% of the time, you can achieve a double scroll configuration. Now, depending on the tip of your inserter, if you have a smaller tip, you have a greater velocity of the fluid, and it results in a faster delivery. However, this is often not in a controlled manner, and the donor orientation can get lost. If you have a wider tip, you can have a slower controlled delivery, but often the fluid fills the anterior chamber, and you have a partial delivery into the anterior chamber, and then you struggle to get the whole donor tissue into the eye. So we looked at, again, a small concept of unidirectional flow. So what we do is we connect the AC maintainer, then we introduce the tip of the injector into the eye, then rotate the tip so that the open end of the scroll is facing upwards. Following this, the flow in the anterior chamber maintainer is stopped, and we disconnect the AC maintainer from the IV tubing. So now the AC maintainer basically plays a role in allowing egress of fluid when the fluid is injected into the anterior chamber. This can be seen in this case, where trypan glue has been injected into the anterior chamber, and you can see the trypan glue flowing out of the anterior chamber maintainer. So this allows a controlled delivery, maintaining the correct orientation of the scroll. And as the chamber does not deepen, the scroll does not lose its orientation, and there is a lesser tendency for the scroll to kind of try and rush out of the main incision. And once you have that, you can slightly deepen the chamber, and since your scroll orientation is maintained, it does not require too much of manipulation to open up the double scroll. So we found that the average unscrolling time was somewhere between 3 to 4 minutes in our series. And the cell loss at 6 months was in the range of about 16.7% in these 20 eyes. Possibly the minimal manipulation that we perform could be responsible for the lower endothelial cell loss. This is again another case where we show the same technique where the AC maintainer is on, tip is inserted into the eye, the tip is rotated, and then we disconnect the IV tubing, stop the AC maintainer, and you can see that the double scroll is just going into the eye. You can just wait, allow the fluid to go out of the AC maintainer. So there is no tendency for the tissue to rush out. And then the double scroll can be using 2 cannulas. You can just tap in the center and in the periphery to get the scroll to open up. And in majority of cases, the scroll is always in the right orientation, and you don't really need to spend time trying to flip it over. And when you're injecting an air bubble, it's important that you don't place the entire air bubble at one go. Always place a small air bubble first, let it settle down, and then you can go and enlarge the bubble. If you try to put a single air bubble at one go, often the tissue can get displaced. So to maintain its centration, it's always a stage approach to air injection. I find it quite useful. Now, looking at the various techniques, you can see that in this case, you have a double scroll, so you can use 2 cannulas. You can either tap in the center or in the periphery, but always watch what happens when you tap the cornea. Don't do a random tapping on the corneal surface. Always helpful to keep the chamber partially formed. If you keep the chamber deep, then what happens is as you tap, the scroll opens up, but then it re-scrolls. In the second video, you will see the orientation is like a taco fold. So we first inject short burst of fluid to get the graft into the kind of a regular configuration with the open end of the scroll facing upwards. So the short burst of fluid is to rotate the donor tissue, and once it has the open end of the scroll is facing towards the surgeon, you use 2 cannulas and you gently tap the cornea to move the tissue to the center of the cornea. Then you can fix one edge of the graft using the cannula, and with the other one, you can tap outside the graft. Sometimes you can even release fluid from the side port. You can release from the main port, but that has lower control, and you can often get the tissue getting stuck in the main incision. So try and avoid that, unless you're a very experienced surgeon like Dr. Samar Basar. The other way of doing it is you pin down one open edge of the scroll, but instead of tapping externally, you can tap internally and do like a drum roll or a carpet unrolling technique, also called as the Dirisamer maneuver. So if you do the tapping, you can get the scroll to open up. And then you tap in the periphery to get this, to allow centration of the scroll. If you have a high myope or a vitrectomized eye with a deep anterior chamber, you may not get a shallow chamber. So then you may need to use an air bubble within the scroll, place a small air bubble, and then use the air bubble to manipulate and open up the edges of the donor DM. Remember that when you're aspirating this air bubble, don't aspirate the bubble at one go. Be gentle, because if you aspirate the bubble quickly, the edges will scroll back again. And once you have aspirated the air, then you can go and place a large air bubble below the graft. If you have a scroll that's facing upside down, deepen the chamber, orient the scroll 90 degrees to the side port, and then give a short burst of fluid directed towards the iris plane. And then you find that this can flip over the graft. Once the graft is in the right orientation, shallow the chamber, and rest of the unscrolling technique is what I have discussed already. If you have a single scroll and a tight scroll, to open it up, you can either place a small air bubble within the scroll to try and open it up, or you can use this cannula, which I designed, which is close at the tip. It has 2 side ports which allow fluid to come out sideways. You can introduce into the scroll, give it a short burst of fluid, which can open up the scroll. Don't be in a hurry to remove the cannula. Depress the paracentesis to release some fluid so that the chamber shallows, and then you can open up the scroll as described earlier. Eyes with ACIOL or shallow chamber or peripheral synechiae where there is not enough room to flip over a graft once it's inserted, I like to using the endo-in technique. So basically, we fold the tissue with the endothelium on the inside, pretty much like a Dmacc graft. Use a microforceps to pull the scroll into the eye, Don't let go till you are sure that the graft is in the right orientation and it's kind of partially opened up. Place an air bubble within the scroll and then open up the graft. We have already seen Dr. Basak describe the mark. You can put an S stamp, F stamp. That is one technique. The other technique is to create a peripheral triangular notch at the edge. And from the stromal side, the notch, the arrowhead moves in a clockwise direction, which tells you the orientation. The other option is to put the asymmetric 1 and 2 marks, which again, the 2 marks joining each other, 1 and 2, it's always in a clockwise direction, which tells you that the orientation is correct. Namrata will be talking about the IOCT, which is again, if you have intraoperative OCT, you can definitely use it to look at the orientation intraoperatively. Air bubble, we already have had Dr. Basak speak about it. Only thing you need to watch out is the patient already has a hydrophilic IOL. Try avoiding long-term tamponade because these can be associated with IOL opacification. And if you keep your pupil myotic, long-term tamponade can also increase the incidence of posterior synechiae. Donor detachments can occur, and these can be managed quite well by rebubbling. So in conclusion, there are several advantages of Dmacc over other techniques. We already heard the advantages, and stepwise approach to learning along with proper selection of initial cases can make the learning curve easier for cardiac surgeons. Thank you. Thank you for your patient hearing.
Thank you, Rajesh. Lovely demonstration. Now, we'll take question after Namrata's presentation. Dr. Namrata, are you
Yes.
ready? So we'll clap together because the both the techniques of that unfolding, and so please.
Am I sharing my slides?
Ma'am, please put on slideshow, ma'am.
Huh?
Slideshow, ma'am.
Yes.
Thank you, Dr. Basak sir, for making me a part of this course, which we've been doing now for so many years. And also, thank you for teaching us how to do Dmacc at RP Center in the workshop that you came a few years ago. And all of us, in fact, have been trained by Dr. Basak sir on Dmacc. So there are no financial or proprietary interests, and Intraoperative OCT microscope is a non-invasive diagnostic technique which renders an in vivo cross-sectional view of the optical tissue. And we have the microscope integrated OCT, although there are various forms which are available. And the advantage of this when you're doing Dmacc is that it allows a dynamic visualization. So you can continuously and simultaneously see what is happening. Of course, the flip side is that it is expensive and it may not be available at all centers. So like Dr. Basak sir said, we are preparing our own tissues, and there are very few eye banks which prepare the tissue and give it to us. So I would be discussing the donor dissection and the host dissection. So as far as the donor dissection is concerned, probably and possibly it does not make too much of a difference because the trypan blue dye helps you to do a very good dissection and preparation of the donor. So after partial thickness trephination, this is the Damask membrane is being pulled onto one side. Can be seen here, but nothing great, except when then there are adhesions in some of the cases, then possibly, these can be highlighted here. So this is followed by trephination of 3 millimeters to make the S-shaped stamp, and then you flip this up on the other side, and after putting the S-shaped stamp there, you can put it back, the lid on the other side. It looks like a desmetocele actually, if you see on the intraoperative microscope. So not that you don't require to do it, you can do it even without, and then this is flipped back, and then trephination is done. So this is going to be exactly like Dr. Basak's, because we we all do what he does. So, and this is then put into the Petri dish. Now, this is a case of Dmacc triple in which the desmetorexis is being done, and this is a clear cornea. So probably here, again, you don't need that much of visualization, but even if there are any desmet membrane remnants which are present, these can be easily pulled out and can be seen on this. And this is the desmet membrane roll which is taken in the injector and is then intracamurally injected and then is placed inside. Now this is upside down. This was the very first case I did and didn't put stamp in this. So this is upside down completely. So we just flip it to get it into the correct configuration with the biceps curl upwards, which can be seen otherwise here also as well as here. And then the graft gets stuck to the back of the cornea. So this is just to show the outcome of the same patient. Now, it has a very important role in hazy corneas. For instance, in this, and we published a whole series of this, the cornea is hazy, the edematous epithelium is removed, desmetorexis is being done, and there may be remnants at this point in time when those are also removed, looking at the IOCT. And notice this is a very tight scroll in the anterior chamber. And again, this is now the graft is folded, and it's difficult to see in hazy cornea such as this, but you tap, get it to the correct configuration of biceps fold upwards. And now this is the correct configuration, and then the air bubble is instilled. So even though you can see a very faint S here, even though you cannot make out, but still one can see on the IOCT to fine tune the same thing. Now, at times what happens is that there may be folds in the Dmacc graft, such as in this case, this is the correct biceps curl upwards. So notice that there is a fold which is present here. So you have to actually go above the graft, looking at the Intraoperative Oct Microscope and inject some fluid there and simultaneously put air. So simultaneously put there and inject fluid there so that the fold becomes mobile, and then that can be addressed. Now again, in case of eye syndrome, you can actually make out where the adhesions are. Not that again you need to do it, you can otherwise also make out. So remove the epithelium and take care of the adhesions which are there between the iris and the overlying cornea. And subsequently, these little pieces would be there in eye syndrome, which will which are still present, and you don't come to know whether they are there or not. So these are removed, doesn't come out piecemeal like it would for Fuchs dystrophy or for PBK. So this is a small piece which has come out, and then another small piece which is coming out from here because this has got partially broken. So when this happens, then IOCT helps you to see if there are any other remnants, and then of course this can be put in, and then air bubble is injected just like I've shown you previously. This is in the post-op period. Now it is useful for failed Dissect also. When you're doing Dmacc, you can remove the graft, and here there is adherence which is present between the graft and the underlying iris, which is again then pulled out, and the graft is quite edematous, and gently it should be pulled out because you don't want iridodialysis there. And then this is loaded in the manner in which it should be in the anterior chamber. So again with the biceps curl upwards, so you don't have to struggle to change the position. You just put it there, and if there's fibrin reaction here, it will show specks of dots. And then again the biceps curl upwards, followed by the air bubble injection, and there it goes and gets stuck to the back of the cornea. So to conclude, intraoperative OCT is a useful tool in the armamentarium of, I think, cornea surgeons, I should say, not only for keratoplasty, but also for ocular surface disease. But it really refines the Dmacc surgeries and helps to see the unseen, more so if you are doing cases which have hazy corneas. And it has to undergo modifications, and of course, it has to become cheaper for everybody to be able to afford. So thank you very much for your kind attention.
So thank you very much. So our next speaker is Dr. Revati.
Yes, sir.
So you will take few questions at the end. We have time.
Yes, sir. Can I start now?
Yes, yes.
So this is, we are going to talk about now. So far we have seen very nice videos about how to do it very properly. Now we are going to see whenever we fumble, what we can do and what problems we can expect. One should understand when we are graduating from Dissection to Dmacc, the whole procedure is entirely different, the Dmacc procedure. So we cannot, whatever we learned in Dissection is not going to help much in facing these problems in Dmacc. So entirely new set of problems you may face, and we have to be prepared for that. So starting from the donor preparation, this is just for a demonstration how an aged donor tissue will behave. It's so brittle, like a piece of paper or a plastic when you are trying to manipulate it. So it can happen in that way, but still, like, you can, if you are getting about 70 to 80% of the tissue what you planned, you can still go ahead and use it. And this is the surgical video. Probably an older video because the method looks a little different. And here the tissue looks quite pliable, but still when the surgeon is trying to pull it, you can see there's some kind of a tear occurs in near that area, 9 o'clock area. And when the surgeon put it in the petri dish, you can appreciate it well. But still this tissue is can be usable. It's not that we have to throw it off or anything. We can still go ahead and use it. So coming to the recipient preparation, as already told many times, Dmacc is a little less forgiving than Dissection. There's no tags in between. The interface is, they can cause a lot of problem if you leave behind a tag. So you can appreciate it well with when we do it with air, the desmotorexis, or even if you do it with visco, as Dr. Rajesh put it, you can again inject, wash it off and inject air and see and look for such tags and then remove them properly before going for injection. And poor visualization also can be a problem, especially in our kind of eyes like dark iris. Prolonged manipulation may lead on to loss of strain also, so we have to strain it properly. And in case of cloudy cornea, what we can debride the epithelium, and also sometimes we can apply glycerin so that we can make it more compact and make the view better before going in for further intraoperative procedures. And intraoperative lighting also we can try. And coming to the donor insertion, this is a very crucial step. Usually it's better to deflate the chamber a little bit, or if you are using anterior chamber maintainer, as Rajesh put it, stop the flow. But what will happen if you keep it in that way? That's it. Like the tissue just got washed out. But luckily, the surgeon could retrieve it, and this is the first post-op day picture, and they went ahead and used it. But every time we may not be very lucky like that. And this video you have to see very carefully. You can see roughly like a kind of faint triangular tissue there that is not, I think, properly, the stain is not that much, and the surgeon tried to open it. That's it. We don't know where it has gone. So it's like, that's why I'm playing it again and again. It's just gone. So this kind of problem can occur. It can go behind the iris also. So later they went ahead and used another tissue, and next day they could find the tissue just peeping out of the pupil, it seems, and then they removed and discarded it. So this kind of problem also can occur. Coming to unscrolling, as already Dr. Rajesh pointed out, a tight scroll can be maybe difficult to manage, and then you can insert the cannula and give small bursts of fluid, and then open it. And if you are very sure about the orientation, you can also even use the same cannula to open it a little bit manually also. May not be a good idea. Then when a large graft can lead on to this kind of origami kind of thing, then you have to orient it properly and make it a single fold, and then go for opening it. And then the sticky tissue, already they mentioned, if there is fibrin, that can lead on to problem. So it's better to wait for complete good hemostasis. And already, as pointed out by Dr. Elmer and Dr. Basser, leave a large air tamponade while you are preparing your tissue. That can lead on to less amount of fibrate. And the upside down donor tissue is another problem. And already, as mentioned by Dr. Fogla, this sign, if you see, then you can be a little bit more sure about your orientation. But still, this video, you can see the orientation looks correct only, and injected. Then I could see that it is the S is upside down. So before manipulation, I put a suture. Then again, we have to tumble it inside the anterior chamber. This is an edited video. It looks very simple, but with a lot of manipulation only, I could gently tumble it, and then I made sure that the orientation is correct. Then I opened it up. So I think I shared this video last time also. We think like, okay, everything went on well. Now we are relaxed, and then I started injecting the air, and then the air, I don't know where the air has gone. Then that's because of that ugly large PI what I made. So that we have to keep in mind, and it's better to go for a very small PI, or sometimes even you can do without PI also if you are quite experienced, and you can do in that way also. So coming to the pupillary block glaucoma, because if you leave behind excessive large air bubble in the anterior chamber for the whole night or something, or if it migrates behind the iris, you can have the problem. And then of course, sometimes you have to immediately release it also. Coming to the donor dislocation, this also can occur, as Dr. Rajesh put it. Case of first, before manipulating it, first make sure with an AIOC202 if possible whether your orientation is correct. Then you can go ahead and rebubble it, and usually expect it in the first week. It's very crucial. If you start seeing a small in between, better to do sequential AIOC202. Especially if you see a small flap like this detachment, then closely follow them up. Gradually, they will go for a larger detachment. Then it's better to go and rebubble. And you can get small bullae in the periphery, especially if your graft size is small. Then the patient, still the symptoms may persist for the patient, though the vision is better. Primary graft failure can occur even in, especially in Dmacc, of course, in the beginning because of excessive handling, and especially if the anterior segment is already compromised due to the primary disease, this is more possible. Graft rejection also can occur, though the incidence is very, very low, 2.8% comparatively with 5-year follow-up, but still it can happen. But the signs may not be very obvious. We have to be very carefully look for this KPs, and then we have to go in for, we have to treat it as the regular graft rejection. So in conclusion, Dmacc is a very gratifying surgery, very elegant surgery. Once you start doing it, you will feel very happy. But this is relatively technically very different from whatever we have done before. So we have to understand this, watch a lot of videos, attend to the master's lectures and their small tips, whatever they are giving. And also you can train yourself with the eye bank eyes or with the artificial chambers, and then you can go for doing it. And during still the learning can be little steeper only. Always keep in touch with your masters and get small clues to go ahead and do the procedure properly. Thank you.
Thank you, Dr. Revati. Wonderful coverage of all complications. So we have not touched anything regarding the infection part, like Elmar's talk was there. Did you encounter any endophthalmitis or interface infection in your series?
Yes, sir. No, sir. In Dmacc or Dissection, so far we have not come across any infection.
I have had 2 cases of interface infection after Dissection. And in fact, one of the tissues that was supplied by the eye bank was following a road traffic accident where the fellow eye was lost. So they didn't have any data on that. And this patient, it turned out to be a very resistant bug. Enterococcus, fecalis, and patient had some liver abscesses which were not treated earlier. So we thought that, initially when we were treating, we thought it could be an endogenous endophthalmitis as well. But the patient did have infection starting 3 days post Dseq, and despite all management, patient lost the eye. So we need to watch out after Dseq. You can have kind of.
So in Dissection in our hospital, we had almost 4,000 Dissection right now, and we had 4 infection, and 1 infection with Bacillus cereus I reported in Cornea Journal long time back. And in Dmacc in my series, only 1 interface infection. And I treated him like giving all intracameral, intrastromal, but it came out as a fungal infection candida, and it went up to endophthalmitis. Then our VR surgeon actually tackled those cases very nicely. Still, the patient is doing fine with 6/12 vision for 4 years, one initial cases. So I had 1 Dmacc and 4 Dseq infection, and 1 I had to, with that Bacillus cereus, I had to be eviscerated. It is so fast, 5 days.
I think we have to be careful when we are going on to this using 1 tissue for 2 patients. And if you're stripping off the Desimac and then using the rest of the stroma for a subsequent case, if your 1 patient develops an infection, chances are you may be putting the second patient at risk of developing an infection. So that also has to be taken into consideration.
So we've had 5 cases of infection with Dseq and 1 with Dmacc. But one thing I've seen that Dseq infections, especially if they are involving the lenticule, they are quite devastating in the sense that it's very difficult to biopsy them. So you would need a intravitreal scissors and forceps to get that little tissue out for biopsying. And the threshold for doing a keratoplasty, a therapeutic one, should be higher for cases of Dseq, because once it's like a time bomb kind of a thing in the interface which is sitting, or interface infection, very difficult. I know Dr. Elmer has done great work on injections and for the Dseq graft, but very difficult, very recalcitrant.
Yeah, I think it does have to do with the different preparation methods. That's probably the main difference between the US. It saves us time on one side, but exposes us to different risks on the other. But no, I think that, as we talked about offline, some of the concepts of basically using broad spectrum antiseptics and really trying to sterilize a donor as much as possible, especially when you have resistant bugs, either to the antimicrobials that are in the media, or don't have an antimicrobial, like against Candida or something of that nature. Really attention to sterile technique, and then surgeon preparation, I think, is very beneficial. When you're talking about using 2 donors, one of the things, again, part of that concept is that, refrigeration does retard growth. And so in between donors, you'd want to make sure that the tissue remains refrigerated to ensure that there isn't that exponential growth of whatever organism you have, whether it be a bacillus or a candida or something like that. So if you are going to use 1 tissue for 2, definitely keep the tissue refrigerated in between.
Yes.
That would be.
Normally, we use those tissue in the same sequence, like second patient is like that.
Mm-hmm.
So it is used within maybe 1 hour, 1.5 hours. So same way, we just transfer the tissue in the preservative media in a small petri dish.
For me, if I have to use the tissue, let's say the next day, I always put the remaining stroma into a fresh bottle of donor storage media. I don't use the same storage media that we used earlier. So that also kind of gives you protection.
And rinsing is always helpful.
Absolutely, yes.
Yeah. Solution to pollution is irrigation, is what they say. So.
Any other topics? Elmar, you need to comment on any Rajesh and Namrata's talk and Revati's talk. Any comments?
No, I mean, I learned a lot. You guys are doing wonderful work. Dmacc is an evolving process here for all of us as surgeons. And so hearing all the different ideas and techniques are just are very helpful to me. So I'm actually happy to be here. So,
Early in the morning in Chicago.
early in the morning. It's early, but can't stop learning. That's what.
Yeah, my request to all of you would be that please try out the unidirectional flow concept that I am currently using. You will definitely find it useful in your cases when you are performing Dmacc. You will find the insertion of the donor to be easier, and also the orientation of the scroll will be maintained much better. Because I've gone through that learning curve over the past 12 years and I've used all kinds of injectors. And I've seen a lot of people present their videos where they shoot the tissue really into the eye. It goes in really fast, becomes horizontal. And I think that's where you lose the orientation. So then you spend your initial time trying to figure out what is the orientation. You try to get the scroll to open up. And if you have a deep chamber, the scroll will go into a single tight scroll. So you cannot really maintain that, what you had loaded into the injector, that's no longer maintained. So I think we all try to improvise on whatever we have been doing. So these are a few tips which has worked in my hands, and I'm pretty sure if you use it and give your feedback that we can take it forward from there and train other surgeons as well.
Dr. Rajesh, I don't use anterior chamber maintainer, but what I do when I inject, I keep another instrument in the side port and dip it so that the fluid will egress from there gradually. At the same time, I'll try to inject the thing too.
I used to do that earlier, but then it becomes a little bit cumbersome. And also, sometimes I've tried inserting my tip of the cartridge by keeping the chamber a little shallow so that I have more space to inject the fluid. But in that process, what happens is your tip of your injector can sometimes catch the iris as you're trying to go in, and you can end up creating a small iridodialysis. Or if your chamber is very shallow, then again, getting like when you're trying to insert the donor, the iris kind of gets into the tip and you find that you're not able to get the donor to enter into the eye. So the AC maintainer helps keep the chamber deep so you can insert the injector very easily and then you stop it. And thereafter you can, so it gives you more working space. So kind of works well.
Thank you.
So any more comments? And we have 2 minutes still to go.
1 minute.
I'll just say that how wonderful it's been to see all of you. I miss all of you. So I hope we can all be together again, but I really thank you very much for including me in your session today. And I learned a lot and it's been fantastic. And I hope to see all of you soon. And I hope you continue to sustain your health.
Thank you so much. What time is it in your place?
5 a.m.
Oh my God.
Thank you, doctors. That was a wonderful session and excellent presentations by all presenters, wonderfully moderated by Dr. Samar Kumar Basak. We will now conclude this session. Thank you.
Thank you. Thank you very much.
Thank you. Bye-bye.
Bye-bye. Take care.